Welcome to the second lecture of the CHW training course. We're going to talk a little bit now about the actual role of a CHW, and I'm going to talk to you about some case studies where the CHW has been found extremely valuable. So we call the CHW part of transformational healthcare, and that's the new buzzword around the Affordable Care Act. Transformational healthcare just means we're in the influx of change, a lot of new things are going on, and it's an exciting time to be a part of healthcare. So oftentimes whenever I talk to individuals about community health workers, I hear them refer to them in many different terms. This can include a CHW or promotora or public health worker, outreach worker, maybe a peer educator or a navigator, or a health coach or an aide. Don't let that confuse you. They are all community health workers. They are just being called something different because of their specific roles. I like to think of the CHW profession the way we think of the nursing profession. You get a basic core training or curriculum, then you move on and specialize, whether it's in pediatrics, geriatrics, or palliative care. In addition to the few job titles I have provided you on a handout, and the ones I have mentioned, there are about 50 others that fall under the umbrella of a CHW, and that list can be found on Blackboard. So regardless of what you call them, there are common roles and responsibilities that are found across the board. The Department of State Health Services Community Health Workers core competencies include these following skills, all of which you are going to be required to get prior to certification. The first one is communication skills. We're going to work on this piece this week. It has to be culturally competent and confident. Then there's interpersonal skills, which includes relationship building, trust, rapport, and peer-to-peer support. Then service coordination skills. You have to identify and access resources, network, and be able to build coalitions. Capacity building. This includes empowerment, leadership, motivation. Advocacy skills, which is the ability to speak up for individuals and overcome barriers. Teaching skills, be able to share information on an individual basis. We'll talk about different learning styles and how to teach to different populations. Organizational skills, how to set goals and plan, juggle priorities, and manage time. And then your knowledge base, knowledge about specific health issues in a specific population, the social service system, and the community. We'll go over all that within 8 weeks. I know it's a lot to go over. So the definition of a CHW, we talked about this a little bit in the last lecture, but I want you to know this front and back. A CHW is a frontline public health worker who is a trusted member and or has an unusually close understanding of the community in which they serve. This trusting relationship enables the CHW to serve as a liaison, link, or intermediary between health and social services and the community to facilitate access to services and improve quality and cultural competence of service delivery. A CHW also builds individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, and advocacy. The last one of those is interesting, isn't it? Knowledge about your specific population, social service system, and community. So let's keep that in the front of our mind because that's very, very important. So now I want you to think hard about your patient population. If you were going to go out today and recruit a CHW that was a trusted member of your patient community, what would that person look like? What would they act like? Where would they come from? Ask yourself, who do you need to reach? Would your CHW look like this guy? Is it this person or this person or this person? What about this person? Would he look like him? Would he look like him? What about her? What about her? What about her? Or would your CHW look like this? Or like this? What would you look for? So equal opportunity employment practices, it never fails that someone's going to ask me, how will you hire someone based upon their race or gender or sexual orientation? Well, legally you can't, but you can hire off things such as their community contacts, their networking ability, their team fit, their ability to foster connections with their patients and clients, their level of commitment to their community in which they're serving, their level of understanding of community and population dynamics. Those things you can hire on. That means that when this guy shows up with the body piercing, the tattoos, the non-traditional hair color, that you don't automatically rule him out. He may be exactly what you're looking for. But then again, the guy with the tie, the nice grooming, he may be exactly what you're looking for. It depends on who your population is. So what makes a CHW different? Well, a CHW does not provide clinical care. They are not going to be out there diagnosing individuals and providing care. They have an expertise that is shared cultural and life experience. Those who have grew up from poverty, those people who have been single moms, those people who have parents with Alzheimer's or parents that they've helped through different diseases. It's that shared culture and life experience. They rely on relationship and trust versus their clinical expertise. They relate to the population served as a peer rather than them as a client. And they achieve results that no other professionals can, or that they won't. So here's some possible roles and functions of the CHW: informal counseling, an educator, assuring services are received. If we make a referral for a patient to go and get, a screening of some sort, I make a referral for a patient to go get an MRI. Well, they are going to assure that that occurs. That they're a cultural mediator. They can provide direct services or basic needs. They may provide nutritional counseling, or they may provide blood pressure checks or blood sugar checks, or check someone with congestive heart failure for their weight. We'll talk about why that is later on in the semester. And they build capacity. They help people overcome barriers so that they can support themselves. And these are the different models of the CHW. You can use them as a team extender, which means an assistant, a navigator, help link different areas, a provider through service, education, or screening. They can do outreach, and they can advocate. There are different fundings under to support a CHW. The Affordable Care Act is the first one. CMS reimbursement, which started in January 2014. Through the Department of Labor, they have apprenticeships where they can get paid. And under CMS, the Center for Innovation, there are lots of grants available. So we're going to talk about some of the programs that have worked. So we're going to talk about all these different ones, and we'll go through them one by one. So the Cambridge Health Alliance created a program to where they integrated a network of 3 hospitals and 12 neighborhood health centers in Cambridge, Massachusetts, and their goal was to reduce chronic disease burden on the community and reduce inappropriate chronic disease spending. Chronic disease is the #1 cause of death and disability, and for every dollar spent on healthcare in the U.S. in 2005, 75 cents of that went towards chronic disease, so it's a huge problem. So the model they used composed of 3 programs. They did a healthy heart program, a tobacco treatment program, and a Stanford chronic disease program. They provided and identified referred patients to the CHW navigator. A navigator scheduled the individual for sessions that they did all these education pieces. The healthy heart, the tobacco treatment, and the Stanford chronic disease are all educational programs. And they had the patients participate in these education and group sessions. The outcome was that It taught patients to manage their own conditions, and for the CHW, it was rewarding to see the patients have positive change. There was a 17% decrease in ER utilization and admissions related to heart disease over 1 year. And I can tell you that in Longview, at Longview Regional, one ER utilization for heart disease can cost anywhere between $7,000 to $25,000. So that's a big savings. The next one was through health imperatives. They implemented what's called a patient-centered medical home model to ensure quality care is done at a lower cost. They did this through comprehensive care, sustained partnerships, coordinated care, and patient-focused care. The patient-centered medical home model essentially is the idea that a patient can go to their doctor and get anything that they need in that one spot. If they need an eye exam, they can get that. If they need a foot exam, they can get that. If they need a dietitian, they can get that. If they need a psychiatrist, they can get that, all in one place. They focused on diabetic and asthmatic patients. They used a team-based approach. They provided health goals which the patient was actively involved in writing. That's important. That doctor don't determine what the patient's goal is, the patient does. For an example, if I was the physician and I told the patient, you need to lose 15 pounds in 6 months. Well, the patient may be thinking, that's impossible. There's no way I can do that. Perhaps I ask the patient what they could do, and they say, well, I think I can do 5. Well, that's a start. That's better than us letting them go and then come back gaining weight instead. And the CHW links the community to the patient-centered medical home and navigated the patient through their goals outside the healthcare systems. They targeted those patients with the highest ER visits. And the outcome was that they closed the gap between the provider and their referrals. They helped facilitate communication between the patient and the provider, and it allowed patients to be much more active in their care. This resulted in a higher compliance rate, 34% higher. And also note that they had no-show rates that were really high before, and those significantly dropped to where they had no-show rates at all. They had no patients who no-showed on them through this entire period. That's amazing, because that costs money as well. So we're going to talk about the VNA Care Network. Basically, the purpose of this was to decrease the disparities that existed among Latinos utilizing hospice services and end-of-life care in the National Hospice and Palliative Care Organization. The model was planned with the community through AHEC. AHEC is the Area Health Education Centers. Ours is in Tyler. They conducted an assessment to identify cultural perceptions, selective CHW hiring based on the population. It was a bilingual, community-based population. They used patient navigators in CHW. They held external health fairs, outreach advisor groups, educations, and they advocated. Internal staff was support to be cultural mediators, patient educators, translators, and healthcare system navigators. The outcome was that over a 3-year period, they had a 24% increase in the utilization of these services among the Latinos, which is money in their pocket. So the next one is the flu-fit model. This happens to be one of my favorites. They increased the rates of colonoscopy screening among patients 50 to 75. Colonoscopies are not something people really want to go and get done. The model they used was from the American Cancer Society, which suggested offering a fecal immunochemical test with every flu shot. So basically, instead of having the invasive colonoscopy, they at least did this FIT test. The CHW educated the patients on the benefits of that screening, and that gives them a test and explains to them how to conduct the test and send it back, and they did that through mail. The outcome was there was a 29% increase across the board in the CRS in primary care settings that implemented the flu-fit. That means that they got that screening instead of doing the colonoscopy, and if it came back with blood in it, then they would go and get the full-blown colonoscopy at that time. And Elder Smile. Elder Smile provides comprehensive dental needs for Hispanic and African American populations in Harlem. Chronic disease directly related to dental health problems, and so they tried to address both issues at one time. The model was the clients came to Columbia University School of Dental Medicine for basic dental needs.